But I don't have diabetes yet, right? Correct. Until one day, the A1C comes back 6.5, and suddenly everybody becomes concerned. Doctor, how did I become diabetic? Well, usually you didn't become diabetic last Tuesday. Welcome to your daily health briefing. I'm Dr. Albert Tackett. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Your blood work comes back. Your A1C is 6.1. And I told you, David, you have prediabetes. And very often the response I get is, okay, doctor, great. At least I don't have diabetes. Well, that's one way to look at it. But here is the way I want you to look at it. Prediabetes is not the good news before diabetes. It's the warning shot. Your body is telling you that the system responsible for controlling your blood sugar is beginning to struggle. You haven't crossed the diagnostic threshold for diabetes. That's good. But this is precisely the moment when I want your attention, because you may still have an enormous opportunity to change where this story goes. And the reason I feel so strongly about this is that I see the same pattern in primary care over and over again. A patient has an A1C of 5.8. We talk about it. A year later, 6.0. We talk about it again. Then 6.2, and then 6.4. And every year, the patient says, but I don't have diabetes yet, right? Correct. Until one day, the A1C comes back 6.5, and suddenly everybody becomes concerned. Doctor, how did I become diabetic? Well, usually you didn't become diabetic last Tuesday. This process has often been developing for years. The laboratory number simply crossed the line that day. And that's why I don't want to wait for 6.5 before we take this seriously. So let's get a little bit into the science, because once you understand what prediabetes actually represents physiologically, that number starts to mean something very different. When you eat carbohydrates, they are broken down into glucose. Glucose enters your bloodstream. Glucose means sugar. Your pancreas produces insulin, and insulin helps move glucose, that is sugar, from the bloodstream into cells where it can be used or stored. But in many people developing type 2 diabetes, the tissues gradually become less responsive to insulin. We call that insulin resistance. So what does your body do? It compensates. Your pancreas produces more insulin. For a while, that works remarkably well. Your blood sugar may even look normal. But eventually, the system begins having difficulty keeping up. It starts struggling. Blood sugar starts creeping higher, and that's often when we begin seeing numbers in the prediabetes range. So prediabetes isn't simply your sugar is a little high. It's evidence that glucose regulation is becoming abnormal. So let's talk about something. What does the A1C actually mean? Because that's the number we throw around very often in talking about diabetes and prediabetes. So let's make the number simple. For most non-pregnant adults, an A1C below 5.7 is considered normal. 5.7 to 6.4 falls in the prediabetes range, and 6.5 or higher can meet the laboratory threshold for diabetes, typically with confirmation when there isn't unequivocal hyperglycemia, meaning when your fasting blood sugar is not also high. A fasting glucose can tell us something similar. Normal fasting glucose is generally below 100 milligrams per deciliter. 100 to 125 is called impaired fasting glucose. That is prediabetes territory. And 126 or higher, when appropriately confirmed, can diagnose diabetes. But here is what I don't want you doing, okay? I know I've thrown a lot of numbers at you. I do not want you obsessing over whether your A1C is 6.3 versus 6.4 as though something magically happens between those numbers. I see that all the time. These cutoffs are clinically useful. Biology, however, is continuous. Your metabolic system doesn't wake up at 6.5 and say, "Congratulations, David, today we are diabetic." That's not how it works. The process exists on a continuum, right? It's a flow. Now, let's talk about something else that I hear from patients all the time when we talk about prediabetes or diabetes. "But doctor, I don't eat that much sugar. I have cut out sugar from my life." And this is probably one of my favorite conversations, I have to confess. Because when I tell somebody they have prediabetes, the next thing they hit me with is, "Doc, that doesn't make sense. I don't eat sweets." Okay. But diabetes isn't simply a disease caused by eating candy. Your overall diet matters. Your body weight and fat distribution matter. Your genetics matter. Your age matters. Your activity level matters. Your sleep matters. Certain medications and medical conditions can also matter. And some ethnic groups carry higher population risk. So you can absolutely develop insulin resistance without sitting at home eating chocolate cake every night. Although, if you are sitting at home eating chocolate cake every night, that probably isn't helping either. You may very well wind up with prediabetes. Now, another thing that's very important is belly fat. Now, we are going to discuss this in another episode because where you carry excess fat matters. Visceral fat, the fat that is stored deeper around your abdominal organs, is strongly associated with insulin resistance and metabolic disease. That's one reason I don't look only at your body weight. I care about your waist circumference. I care about blood pressure, triglycerides, HDL, fatty liver, A1C. These findings often travel together because they are different manifestations of the same underlying metabolic environment. Now, I have spent several minutes telling you why prediabetes matters. So let me give you the part I actually want you to remember. Prediabetes is not destiny. This is just where the story becomes incredibly encouraging. One of the landmark studies in medicine was the diabetes prevention program. Researchers studied people at high risk of developing type 2 diabetes. One group received an intensive lifestyle intervention aimed at losing approximately 7% of body weight and performing at least 150 minutes of physical activity per week. Another received metformin. Another received placebo. Over roughly 3 years, the intensive lifestyle intervention reduced the incidence of diabetes by 58% compared with placebo. Metformin reduced it by about 31%. Think about that. We are not talking about some exotic treatment. Weight loss, physical activity, lifestyle change, and a major reduction in progression to diabetes. Now, this is fantastic for everybody who tells me all the time, "Doc, is there a natural way to do this?" Yes, I just gave it to you. It's called weight loss and exercise. That's why I call prediabetes a warning shot, because a warning gives you time to respond. And this is where I want to change the way you emotionally react when your doctor tells you that you have prediabetes. Don't hear, "I am sick," and don't hear, it's nothing. What I would like you to hear is I have an opportunity, because I would much rather have this conversation with you at an A1C of 6.0 than meet you several years later with an A1C of 9.5. At 6.0, we are talking about prevention. At 9.5, we may be talking about medication intensification, kidney disease screening, eye examinations, neuropathy, and long-term cardiovascular risk. That's an entirely different conversation. So when your doctor tells you your A1C is creeping up, that's not nagging. That's an opportunity to intervene before the consequences arrive. Now, not everybody with prediabetes needs medication. Let's be clear on that. Lifestyle intervention remains foundational, but medication may be appropriate for some higher-risk patients. Metformin has long been considered in selected patients at particular high risk of progression. And today, we also have much more effective treatments for obesity itself. That's important because if excess adiposity is one of the major drivers of insulin resistance, treating the obesity can dramatically change the metabolic environment. So sometimes the right conversation isn't merely how do we lower the glucose? It's what is driving the glucose higher in the first place? That's a much better medical question. So if you've been told you have prediabetes, here is what I want you to do next. First, know your number. Don't just say, my doctor said my sugar was borderline or a little high. What was the A1C? Was it 5.7? Was it 6.1? Was it 6.4? Know exactly where you are. Secondly, look at the trend. One number is useful. 3 years of numbers tell me a full story. If you went from 5.7 to 5.9 to 6.2, I am paying attention. Thirdly, if you are carrying excess weight, please address it. Even modest weight loss can produce meaningful metabolic improvement. And if you have obesity, talk to your physician about the full range of evidence-based treatments options we have today that can treat both prediabetes, diabetes, and obesity. Fourth, move your body. Aim toward at least 150 minutes of moderate physical activity per week and include resistance training. Muscle is an important site of sugar disposal. Using it is metabolically useful. Fifth, look at what you are drinking. Soda, sweet tea, juice, sugary coffee drinks, alcohol, liquid calories can add up incredibly quickly. Finally, follow up. Prediabetes isn't something I want written in your chart and forgotten for 5 years. We need to see where it's going. So, as we wrap up this episode, if your A1C is 6.1, I don't want you terrified. I don't want you celebrating because it isn't 6.5 either. I want you paying attention because your body has given you something incredibly valuable, a warning sign. You haven't had the stroke. You haven't developed kidney disease. You haven't developed diabetic neuropathy. And you haven't necessarily developed diabetes. You are standing earlier in the story. And earlier is exactly where prevention works best. So don't wait for prediabetes to become diabetes before deciding it's real. Take the warning shot seriously. Lose the excess weight if you need to. Exercise, improve your nutrition, know your numbers, follow the trend, and work with your healthcare team while you still have opportunity to change the trajectory. I'm Dr. Albert Takem, and that's your Daily Brief. I will see you next episode because the fight for your health doesn't stop here. This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Taken, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.